Hello everyone, it's Dr. Locklear here, and we are continuing our studies on acid-base balance, and today this recording is going to focus on respiratory acidosis. So this is Exemplar 1C, and this begins on page 22 in your Pearson text. Our learning outcomes, what is the pathophysiology? So how does respiratory acidosis occur? What is the causes of respiratory acidosis? And as a nurse, well, if we can detect the causes early, we can possibly prevent the patient from having severe harm from this because we can assess and report. Compare the risk factors and prevention of respiratory acidosis, identify the clinical manifestations of respiratory acidosis, summarize the diagnostic tests and therapies used by the interprofessional team, and how do we use this information to collaborate care. Differentiate care of patients with respiratory acidosis across the lifespan, so how does it affect children versus adults? And apply the nursing process in providing culturally competent care to individuals with respiratory acidosis. What do we do when we observe? What do we do when we do our physical assessment? Which interventions are going to help improve and restore proper respiratory function? So let's get started. So what is our overview? Respiratory acidosis is caused by an excess of dissolved carbon dioxide or carbonic acid. It is characterized by a pH less than 7.35 and a PaCO2 greater than 45. So in acidosis, the pH goes down and the PaCO2 goes up. So kind of remember acidosis for respiratory going in the opposite direction. And that's kind of how I remember it. Respiratory acidosis may either be acute or chronic. In chronic respiratory acidosis, the bicarbonate level is higher than 28 as the kidneys compensate by retaining bicarbonate. And we're going to talk about the differences of acute and chronic. What's the pathophysiology? Both acute and chronic respiratory acidosis result from carbon dioxide retention, so you're retaining CO2 in your lungs, caused by alveolar hypoventilation. So our alveoli in the lower part of our lungs is not exchanging O2 correctly, and so you have a lack of ventilation. Hypoxemia, which is decreased oxygen, frequently accompanies respiratory acidosis. Acute respiratory acidosis. So what do we see in acute versus chronic? Acute respiratory acidosis results from a sudden failure of ventilation. This is the exchange of oxygen and carbon dioxide. Chest trauma, aspiration of a foreign body, acute pneumonia, and overdoses of narcotics such as morphine or sedative medications can lead to this condition. Because acute respiratory acidosis occurs with the sudden onset of hypoventilation, so you're not breathing enough, for example, with cardiac arrest, the PaCO2 rises rapidly and the pH falls markedly. So the PaCO2 is going to go up because you're retaining CO2 and you're becoming more acidotic, so the pH will be low. A pH of 7 or lower can occur within minutes, resulting in death if not corrected. The serum bicarbonate level is unchanged initially because the compensatory response of the kidneys continues over hours to days. So what is hypercapnia? This is increased carbon dioxide levels. It affects neurologic function and the cardiovascular system. Carbon dioxide rapidly crosses the blood-brain barrier. Cerebral blood vessels dilate, and if the condition continues, intracranial pressure increases and you will have papillary edema, which is swelling and inflammation of the optic nerve where it enters the retina, so of course in the eye. Peripheral vasodilation also occurs and the pulse rate increases to maintain cardiac output, so you'll be very tachycardic. The primary problem is alveolar hypoventilation, so you're not breathing enough, with increased PaCO2. So if I'm not breathing properly, my lungs are retaining CO2. Respiratory acidosis can be caused by acute pulmonary edema, central nervous system depression, chest wall disorders, trauma, oversedation, asthma attacks, obstructive sleep apnea, obesity, and pulmonary infections. So anything that affects those alveoli from having proper ventilation can lead to hypoventilation. So what is chronic respiratory acidosis? It is associated with chronic respiratory or neuromuscular conditions such as COPD, asthma, cystic fibrosis, and multiple sclerosis. These conditions affect alveolar ventilation because of airway obstruction, structural changes in the lung, and limited chest wall expansion. So here again, retaining CO2 because you have hypoventilation. Most patients with chronic respiratory acidosis have COPD with chronic bronchitis and emphysema. In chronic respiratory acidosis, the PaCO2 increases over time and remains elevated. So it's not uncommon in a COPD patient with bronchitis and emphysema to have a consistently high CO2 because they're retaining it. And as you saw in COPD, you'll have a barrel chest because the alveoli are expanded and the air is trapped. It can't get out. The kidneys retain bicarbonate, increasing bicarbonate levels, and the pH often remains close to the normal range because of adequate metabolic compensation. So the kidneys are kind of doing their job at this point. The acute effects of hypercapnia, so hypercapnia is increased carbon dioxide levels, may not develop when carbon dioxide levels rise gradually, allowing compensatory changes to occur. So in chronic, as it rises slowly, the body compensates because it has time to compensate. When carbon dioxide levels are chronically elevated, the respiratory center becomes less sensitive to the gas as a stimulant of the respiratory drive, so it gets immune to it. The PaO2 provides the primary stimulus for respiration, so I need some oxygen. Patients with chronic respiratory acidosis are at risk for developing carbon dioxide narcosis with manifestations of acute respiratory acidosis if the respiratory center is suppressed by the administration of excess supplemental oxygen. So these patients can't have a lot of oxygen. A lot of times, maybe 1 liter, 2 at the most, because they can get oxygen in, they just can't get it out. Manifestations include confusion, tremors, and convulsions. Coma can occur if blood levels of PaCO2 reach 70 or higher. Patients with chronic respiratory acidosis can tolerate a PaCO2 levels that are much higher than normal because their body compensates, and it's chronic. It happens slowly. Safety alert. Carefully monitor neurologic and respiratory status in patients with chronic respiratory acidosis who are receiving oxygen therapy. Immediately report a decreasing level of consciousness or depressed respirations. Again, you have to be careful how much oxygen you give these patients. So what are the risk factors? Acute or chronic lung disease such as pneumonia or COPD or trauma is the primary risk factor for respiratory acidosis. Other conditions that depress or interfere with ventilation are narcotic analgesics such as morphine, propofol, fentanyl, anything that can put you in a deep sleep. Airway obstruction and neuromuscular disease such as Guillain-Barré also are risk factors for respiratory acidosis. Look at table 1-1, and that is back in the chapter where it talks about the acid-base balance. Look on page 23, clinical manifestations of respiratory acidosis. And while you are looking at that, I'm going to go back to table 1-1 in our concept. That's on page 6. And I went over that table very thoroughly in that lecture. Make sure you review that table. Excuse me. Clinical manifestations. Before we go, yes, look at clinical manifestations on page 23. The etiology, diseases of the airway such as asthma, COPD, disease of the chest, drugs that suppress breathing, opioids, or alcohol. So we didn't see alcohol in the reading, that's in our table. And obstructive sleep apnea. Clinical manifestations, acute, headache, warm flushed skin, elevated pulse, blurred vision, irritability or altered mental status, decreasing level of consciousness, cardiac dysrhythmias and cardiac arrest as you have tachycardia, chronic, weakness, dull headache, sleep disturbances with daytime sleepiness, impaired memory and personality changes. Clinical therapies assist with identification and treatment of the underlying cause. Observe for altered respiratory excursion, rate and depth. Auscultate the breath sounds. Assess and report. Assess level of consciousness and progressive changes. Place in a semi-Fowler position or Fowler position as tolerated. Encourage the patient with chronic respiratory acidosis to use pursed-lipped breathing. Administer oxygen as indicated by mask, cannula, or mechanical ventilation. Increase or decrease respiratory rate on ventilator, modify respiratory settings as needed, and of course respiratory therapy will be monitoring this as well. Administer medications as indicated, for example, Narcan if you have an overdose of morphine or some other drugs. Use continuous positive airway pressure or CPAP. So the manifestations of acute and chronic respiratory acidosis are different. In acute respiratory, as we saw in the table here, the rapid rise in the PaCO2 levels causes manifestations of hypercapnia, which is increased carbon dioxide levels. Cerebral vasodilation causes manifestations such as headache, blurred vision, irritability, and mental cloudiness. If the condition continues, the level of consciousness progressively decreases. Rapid and dramatic changes in ABGs can lead to unconsciousness and ventricular fibrillation. So you need to do a thorough assessment. Any changes in mental status, you need to notify the healthcare provider. Listen to their heart, listen to their lungs. Every time you go in a patient's room, you should assess their level of consciousness and document that as well. Rapid and dramatic changes in the EKG can lead to unconsciousness and ventricular fibrillation, a potential lethal cardiac dysrhythmia. The skin of the patient with acute respiratory acidosis may be warm and flushed, and the pulse rate is elevated. The manifestations of chronic respiratory acidosis are weakness, dull headache, sleep disturbance, daytime sleepiness, impaired memory, personality changes also may be manifestations of chronic as well. Patients with acute respiratory failure require treatment in the ED or intensive care unit. The focus is on restoring adequate ventilation and gas exchange. Acute respiratory acidosis is often the result of inadequate breathing patterns, hypoventilation. It results in retained carbon dioxide and inadequate intake of oxygen. So with hypoventilation, you're not just retaining CO2, you're not getting enough oxygen in as well. As a result, hypoxemia often accompanies hypercapnia, requiring administration of supplemental oxygen. The administration of oxygen to the patient with chronic hypercapnia, such as the patient with COPD, must be done cautiously to prevent removing the respiratory drive in those who breathe as a result of minor hypoxia. And so look back on page 22. Hypoxemia is decreased oxygen. Hypercapnia is increased carbon dioxide levels. You need to know those two terms. Collaboration. Care of the patient experiencing respiratory acidosis involves the efforts of the entire healthcare team. A respiratory therapist may provide breathing treatments and related therapies as ordered. Consultation with the pharmacist and the patient's primary care provider prevents administration of medications that may be contraindicated. Patients who are using accessory muscles to breathe may require increased caloric intake and the participation of a dietitian, because as you increase your efforts to breathe, it burns up a lot of energy. A lot of times when patients are on a ventilator, they get too fed because they're ventilated, they can't eat. ABG, so our diagnostic test. We've already talked about ABG, so this should be repeat for you. ABG show a pH of less than 7.35 and a PaCO2 of more than 45. In acute respiratory acidosis, the bicarbonate level is initially within the normal range, but increases to greater than 28 if the condition persists, because it's trying to compensate with the bicarb. In chronic respiratory acidosis, both the PaCO2 and the bicarbonate may be significantly elevated because it's always trying to compensate, and it's done it over a long period of time. Serum electrolytes may show hypochloremia, chloride level below normal, in chronic respiratory acidosis. Primary function studies may be done to determine whether chronic lung disease is the cause of respiratory acidosis. So they'll do a test to look at how you're breathing, how your lungs are functioning. Additional diagnostic tests may be done to identify the underlying cause of respiratory acidosis, such as a chest x-ray, sputum studies, which is cytology and a culture, may be ordered to identify an acute or chronic lung disorder. If drug overdose is suspected, then they will do a serum level of the drug. They'll do a drug screen on you to see what you've had. Pharmacologic therapies, bronchodilators to open the airways, antibiotics to treat infections. If excess narcotics or anesthetics are the cause, then they use narcotic antagonists such as Narcan to reverse the effects. Respiratory support. Treatment of respiratory acidosis, either acute or chronic, focuses on improving alveolar ventilation and gas exchange. Of course, we got to breathe. We got to get out of that state of hypoventilation. Patients with severe respiratory acidosis and hypoxemia may require intubation and mechanical ventilation so they're getting enough O2 in their lungs. The PaCO2 level is lowered slowly to prevent complications such as cardiac dysrhythmias and decreased cerebral perfusion. In patients with chronic respiratory acidosis, oxygen is administered cautiously to prevent carbon dioxide narcosis or buildup of the CO2. Remember, with chronic, they can breathe in oxygen, they just can't get it out. Pulmonary hygiene measures may be instituted, such as deep breathing, coughing, breathing treatments, percussion, and drainage. Adequate hydration is important to promote removal of the respiratory secretions, so some IV fluids and possibly tube feeding. Infants and children. Respiratory acidosis is an acid-base disturbance caused by the elevation of PaCO2 with resultant excess of carbonic acid owing to primary defects in lung function or changes in the respiratory pattern. Children with asthma, pneumonia, airway obstruction, acute pulmonary edema, acute respiratory distress syndrome, which is ARDS, head trauma, and poisoning are at high risk for respiratory acidosis. In these children, the critical ABG result is increased PaCO2, indicating increased carbonic acid. Serum pH can be normal or decreased. Clinical manifestations of respiratory acidosis in children of all ages are similar to adults. Decreased level of consciousness, increased intracranial pressure, and eventually coma. Acute respiratory acidosis may result in tachycardia and arrhythmias. Nursing management includes ongoing assessment of mental and respiratory status every time you go. You may be one-on-one with that client. Positioning, suctioning to clear the airways, and encouraging deep breathing. Older adults. Many illnesses common to older adults may result in acidosis or acid-base imbalance if not properly treated. COPD, chest wall abnormalities, pneumonia, respiratory muscle weakness are some of the common causes. CO2 retention from hypoventilation occurs, and the compensatory response is the bicarb retention by the kidneys. Older adults are more prone to have COPD. Outcome depends on the nature of the illness and early diagnosis and treatment. And so look at patient teaching on page 24. Children with asthma, airway obstruction, influenza, and pneumonia are at risk for respiratory acidosis. You want to teach the parents prevention methods such as, and yes, we teach the children as well. You are able to teach a 12 and 13-year-old and they can learn, but yes, anybody underage definitely needs an adult or someone that is caring for that person. I just want to make that note. Deep breathing several times a day, signs of infection, positioning to facilitate chest expansion, medication administration, and use of any ordered devices such as home respirators and nebulizers. And so whoever you're teaching, the patient, if they are a child, and the caregiver, you need to teach them when to call 911 and to know the warning signs of these airway disorders so they can call EMS when they need to. Not wait till, the longer you wait, the more complicated it's going to get. And here's your teaching instructions for the parent and the child. Nursing process. Nursing care of patients with respiratory acidosis is focused on improving breathing patterns and maintaining a patent airway. Because of the link between smoking and chronic pulmonary diseases, nursing care may include teaching patients how to make healthier lifestyles choices. Assessment, observation, and patient interview. Ask the patient about current manifestations such as headache, irritability, lethargy, difficulty thinking, blurred vision, other symptoms, duration of symptoms, and any precipitating factors such as drug use or respiratory infection, chronic diseases such as cystic fibrosis, and you see those in children, or COPD, and current medications, and smoking. I'm really surprised that they didn't list smoking here. The physical exam, examine mental status and level of consciousness. Vital signs, look for elevated heart rate and low respiratory rate, skin color and temperature, and rate and depth of respirations, pulmonary excursion, how is your chest expanding, and lung sounds, how do they sound? Possible nursing diagnoses, ineffective airway clearance, of course, anxiety. We feel very anxious when we can't breathe. Ineffective breathing pattern, decreased cardiac output because of the lack of oxygenation, and that affects perfusion. And of course, impaired gas exchange, which is oxygenation as well. Planning, our desired outcomes. Planning for the patient with respiratory acidosis involves restoration of acid-base balance and appropriate treatment for any underlying disease or cause. Expected outcomes include resolution of the underlying illness and the patient's maintaining adequate fluid intake, so staying hydrated, adequate oxygenation saturation greater than 90%, normal PaCO2 levels, and maintaining pH balance. Implementation. Frequently assess respiratory status. Frequently assess respiratory status, including the rate, depth, effort, and oxygen saturation levels. Decreasing respiratory rate and effort along with decreasing oxygen saturation levels may signal worsening respiratory failure and respiratory acidosis. Safety alert. Frequently assess level of consciousness every time you interact with the patient. A decline in level of consciousness may indicate increasing hypercapnia and a need for increasing ventilation support, such as intubation and mechanical ventilation. So how do we promote gas exchange? Promote gas exchange by promptly evaluate and report ABG results to the physician and respiratory therapist. Rapid changes in carbon dioxide or oxygen levels may necessitate modification of the treatment plan to prevent complications of overcorrection of respiratory acidosis. Place in semi-Fowler to Fowler position as tolerated. Elevating the head of the bed promotes lung expansion and gas exchange. Administer oxygen as ordered. Carefully monitor response. reduce the oxygen flow rate or percentage, and immediately report increasing somnolence, which is like an altered cognitive state. You're getting really sleepy and lethargic. Supplemental oxygen can suppress the respiratory drive in patients with chronic respiratory acidosis. Promoting effective airway clearance. I'm sorry, but while I'm recording, it won't let me go back to the next screen, and I did skip it. So we're at promoting effective airway clearance. Frequently auscultate lung sounds, whether the patient is on or off a mechanical vent. Increasing adventitious sounds or decreasing breath sounds, faint or absent, may indicate worsening airway clearance due to the obstruction or fatigue. Encourage the patient with chronic respiratory acidosis to use pursed lip breathing. Pursed lip breathing helps maintain open airways throughout exhalation, promoting carbon dioxide elimination. Frequently reposition and encourage ambulation as tolerated. Repositioning, sitting at the bedside, and ambulation promotes airway clearance and lung expansion. And you also want to have effective coughing and know how to teach them to do pursed lip breathing. Encourage fluid intake. Fluids help liquefy secretions and hydrate respiratory mucous membranes, promoting easier airway clearance because it's less thick and you can cough it up. Administer medications such as inhaled bronchodilators. It opens up the bronchi. Inhaled bronchodilators help relieve bronchial spasms and dilates the airways. Provide percussion, vibration, and postural drainage as ordered. Pulmonary hygiene, which is what I just read, measures such as these help loosen the secretions as well. Reduce anxiety. Anxiety is very common as a result of both hypoxia and hypercapnia triggered by insufficient oxygen supply to the neurons. Patients with respiratory disorders commonly experience anxiety that is eliminated by improved ventilation and oxygenation. The nurse can help the patient reduce anxiety levels through the following interventions. Remain with the patient and monitor for changes in condition, as someone being there will help calm the patient. Explain procedures and treatments such as using short, simple sentences. Providing clearly understood information reduces fear. Talk to them, communicate. Speak up where they can hear you because we're having to wear masks, and communicate in terms that they understand, layman terms. Reduce environmental stimuli and use a calm, reassuring manner. You stay calm, because if you're calm, they will stay calm. And again, just talking to them, get them distracted. These measures will help reduce the anxiety. Allow supportive family members to remain with the patient because they're familiar with them. They feel comfortable with them. So, reduce risk for injury. Patients with respiratory acidosis may experience blurred vision and an altered level of consciousness, putting them at risk for injuries. Nurses working with these patients should assess level of consciousness, mental status, and orientation frequently every time you interact with the patient. Place call alarm controls within reach. Manage rest and activity patterns to improve gas exchange and reduce oxygen demands. Administer supplemental oxygen as needed to prevent cellular hypoxia and tissue damage. Follow your physician's order as pertaining to how much. Plans for discharge. Planning and teaching for home care focus on the problem that caused the respiratory acidosis. So you're going to teach the patient and family about preventive measures and equipment that may be used in the home. The patient who developed acute respiratory acidosis as a result of acute pneumonia or chest trauma may require only teaching to prevent future problems. If acute respiratory acidosis occurred secondarily to narcotic overdose, determine whether the drug was prescribed for pain or whether it was an illicit street drug, and then get them the resources that they need if they have an illicit street drug problem. Provide teaching to the patient who requires continuous narcotic medication. Refer the patient using illicit drugs to Substance Abuse Counselor Treatment Center, Narcotics Anonymous as appropriate, and refer the family to support groups, but you have to have a physician order to do that. You can't just do that. Your physician has to make those referrals. For patients with chronic lung disease and their families, discuss ways to avoid future episodes of acute respiratory failure. Encourage the patient to receive immunization against pneumococcal pneumonia and influenza. Discuss unless there's some contraindication that they cannot have these. Okay. Discuss with the patient and family ways to avoid acute respiratory infections such as good hand hygiene, avoid crowds, and respiratory cough etiquette. Cover your mouth when you cough. Provide instructions regarding measures to take when respiratory status is further compromised. The patient and family should be alerted that symptoms such as headache accompanied by blurred vision or weakness, irritability, confusion, sleep disturbances, memory impairments warrant immediate medical attention. Shortness of breath or inactivity and intolerance are often the earliest symptoms of worsening respiratory status. Wheezing, grunting, use of sensory muscles, and cyanosis are often late signs. And change in mental status is an early sign as well. Evaluation. The patient maintains a patent airway. Patient maintains appropriate breathing patterns to meet oxygen demands. Patient remains conscious and does not display anxiety, indicating potential hypoxia. ABG reflects pH and PaCO2 within an acceptable range for the patient. So assess and report, okay, and do a thorough assessment of your lungs and your mental status and your ABGs and your pulse ox. Thank you.